Buenos días a todos y a todas. Disculpen la demora.
Good morning,
Tuvimos
everyone.
algunos
We are so
inconvenientes
sorry for the
técnicos este
delay.
viernes
We
13,
had a couple of
pero
technical
ya pudimos
issues because it's
solucionar y
Friday
ya
the
estamos dando
13th,
comienzo a la
but we
edición
were
número
able to resolve them, and now
49
we're
del
starting with
programa de
the
webinar,
49th
webinars
edition
de
of
RedETSA,
the
en este
webinars
caso
programs of
titulado
RedETSA,
Priorización en
in
Evaluación
this
de
case
Tecnologías
called
Sanitarias, una herramienta
Prioritization
clave
in
para optimizar los
Healthcare
resultados
Technologies,
en
a
salud.
key tool to
Algunos
optimize
aspectos
the
técnicos antes
results
de
in healthcare.
comenzar. El
Couple
webinario se va a
technical
realizar en idioma todo español,
topics
pero hay
before we start the
interpretación en
webinar will
inglés.
be in
Pueden
Spanish, but
seleccionar esta
there's
opción
interpretation
clicando en el
into
icono del
English. You can
globo
select
en la parte
the
inferior del
option
Zoom.
clicking on the globe.
Esta sesión va a ser grabada como todos los
And
webinarios de
this
RedETSA
session
y van a
will
tener la
be
disponibilidad de este
recorded like
webinar
all the
y de todo el
RedETSA
resto en la
webinars, and
página de RedETSA
you will have the possibility
www.redetsa.org
to take a
y
look
también
at
en
them
Pajo
at
TV, en
the
YouTube.
RedETSA
¿Sí?
webpage and at
Bueno,
Pajo
agradecemos
TV
a
in
todos los
YouTube.
miembros, a los presentes, en
So
especial
we
a los
thank all the
expositores,
members
y
here,
voy a darle la
especially all the
palabra
speakers today, and
a
I will be
Alexandre
handing the
Lembrúer
floor
para
to
decir
Alexander
la apertura
Lembrúer
de este webinario.
for the opening remarks.
Muchas gracias. Muchas gracias, Malén.
Thank you so much, Marlene. We apologize for the delay. We had a couple technical issues last minute that we hadn't been able to resolve, but thank you so much for your patience. So it's a pleasure to be here with all of you, with our colleagues, our friends from RedETSA. So this is our 49th webinar. We're almost on number 50, and we are celebrating very important milestones here. 50 webinars very shortly. These are important achievements. Now, today, we have a very important matter to talk about for the technology assessment process, especially prioritization of technologies. You probably know and apply this methodology of prioritization day to day. But we are going to have a moment to reflect upon this matter a bit more and bring experiences from countries and members of our network in this discussion. So, this is prioritization and assessment of health technologies as a process, a strategic process that is indispensable for health systems because we know that it's impossible to assess all technologies. Of course, no agency could have the capacity or has its capacity to assess all the technologies that are in the market that are registered by the regulatory authorities. So, implementing a framework for prioritization explicitly is a strategic need that can guarantee or at least contribute to an institutional efficiency and also for better access. So we know that this process seeks to contribute to the optimization of resources that are obviously limited, both financial and human resources, to focus on the technologies that we have so that they can have a significant impact, both health-wise, financially, to be able to drive and boost the health systems. And the technology assessment authorities want to strengthen their own legitimacy and transparency to avoid effort duplication or to try to not assess technologies that are not very important or not leaving out assessment of technologies that could have a lot more impact for the health system. And this helps. Having this kind of methodology has reduced the political discretionality and has helped encouraging transparency. We know that this is essential for any public entity, but I would say that even more so for the health technology assessment entities, because many times they are seen as entities that have barriers to access and that have difficulties for technology to be available. So having this explicit and transparent criteria helps in the process of legitimacy with the civil society and the population, and also the trust that people have knowing that the entity is doing important work to improve the efficiency of the system and the equity of the system. So we need to ensure that these decisions are based on solid evidence, alleviating the burden of disease in the country and caring for the needs of the population. And with this, we can have better efficiency, avoiding unnecessary assessments or that have low added value, and thus promoting any structuring needed, like clinicians, patients, and funders in the system. And this is related to the decisions, the national decisions in health and the universal access to health. So today we're going to have these elements in discussion. And for this, we have representatives of 3 countries that are applying methodologies to be able to share. So with our previous webinars and our meetings with RedETSA, and I wanted to thank everyone for the experience we're going to have, the experience of Argentina. And we know I'm not sure if he's connected already. I don't know if you know, but he very recently became a dad a couple of hours ago, actually. And but his commitment to RedETSA is so strong that he has told us that he will be doing his presentation, even if it's at the end of the session. So that when we greet him, we can congratulate the newest father of RedETSA, who will also going to be listening to the experience of the Dominican Republic with Madeline Martinez, who's already connected also. She had a connection problem, but we were able to resolve that. And also the experience of Uruguay with Alejandra Crossi and Diana Perez, who are also connected already. I will leave the schedule for today for moderator Malin Holman, and I also want to thank once again Malin. I think you all know her work, to be able to ensure that our RedETSA Secretariat works well always in supporting the network and all of its activities. I also want to thank Maria Canuto, who's connected, Caroline Bregman. You all know her as well. And you know that she's working in RedETSA day to day. And I also want to thank Frank Raposa, who's here with us today. We also had another problem today. That our assistant, Lara Ferrer, who always supports us at the seminars, is unfortunately sick today. So Frank, at the last minute, came to support us with the administrative and structure aspects in the Zoom room. So we have over 250, almost 220 participants online. And I now hand the floor to Malin to start the session. Thank you so much. Unfortunately, I'm not going to be able to stay. I have a meeting at my daughter's school in 15 minutes, but I leave you in great hands. Thank you so much for your participation and have an excellent session. Thank you.
Muchas gracias, Alejandro, por su
Thank you.
apertura.
Thank you, Alexandre, for
Bueno, es un
your
gusto
opening
moderar este
remarks.
webinario sobre un
It's
tema tan
a pleasure
crítico
to
como
moderate
es
this
la
webinar on
priorización de
such a
las
critical topic like
tecnologías
the
a evaluar e
prioritization
incorporar para
of
optimizar
technologies to
resultados
be
en
assessed and
salud.
incorporated to
Y
optimize health
presentaremos distintos
results.
marcos de
We will be
priorización, como
presenting
comentó
different
Alexandre, que permiten
prioritization framework, as
seleccionar qué
Alexandre
tecnologías
mentioned, that
evaluar en
allows
función de
selecting which
criterios claros
technologies
y
to assess under
transparentes.
which
Nuestro
clear
primer
and
orador,
transparent criteria. And our
que
first
afortunadamente pudo
speaker,
llegar y como
who
bien
was
comentó
fortunately able
Alexandre,
to be here,
es
and as
el papá
Alexandre
más nuevo que
mentioned,
tenemos
he is the
en
newest
RedETSA
dad that we
seguramente,
have at RedETSA,
Manuel
surely.
Donato. Manuel
Manuel Donato.
es
Manuel
farmacéutico de
is
la
a
Universidad Nacional
pharmaceutical
del Sur
professional
de
from
Argentina, un
Universidad
máster en
Nacional del
actividad
Sur of
clínica de la
Argentina and
Universidad de
has a
Buenos
master's
Aires.
degree
Manuel trabajó
from
en la Comisión
Buenos Aires
Nacional de Evaluación de
University, and he
Tecnologías
worked at the National
Sanitarias y
Commission
Excelencia
of
Clínica en CONETE
Assessment
como
of
supervisor
Healthcare
general y
Technologies
director
as
ejecutivo.
a
Actualmente es
executive
investigador y
director.
docente del
He's
Centro de
currently a
Evaluación de
researcher and
Tecnologías
professor of
Sanitarias,
the Center
Acceso
of
e
Evaluation of Health
Innovación,
Technologies,
CETSAI,
Access
y
and
la
Innovation,
Universidad de
CETSAI,
Salud, que hace poco
of
también
De
ha
Salud
ingresado
University,
como miembro a RedETSA.
who recently became a member
Bueno,
of
los dejamos
RedETSA.
con Manuel.
We now leave you with
Espero que esté
Manuel.
más o menos despierto,
I hope he is sort
pero
of
que
awake,
seguramente, bueno, nos va a
but
deleitar mucho con su
he will
presentación.
surely
Manuel, eu
delight us with his
percebi que
presentation.
está fazendo
Manuel,
aqui
I
o
don't know
papel
very well
aqui.
what
Eu
you're
creio que
doing
deve
here
ser o
today.
único papá del
I
mundo que
think you're the
estaria
only
aqui
dad
no
in the
webinar
world
da
who would
RedETSA.
be
Quiero te
here at this
agradecer muito
webinar
por essa
today.
consideração
But we
e
are
uma
so
vez mais
thankful for having you
felicitações pelo
here,
muito
and
empenho
once more,
especial que dedicação da
congratulations. We're going to
RedETSA
give
no
you a
projeto
special award for
demonstração.
dedication to
Muitas
Redetza
graças
for
e
this
felicitações por esse
demonstration.
momento tão
Thank
especial.
you so much, and
Bueno, muchísimas
congratulations in
gracias
this
por
special
las
moment. Thank you
felicitaciones. No,
so
no quería que
much
mi
for your
hija,
congratulations. I
no
didn't
quería que
want
se
my
sepa en toda Latinoamérica, pero bueno,
my
Alejandra,
I
felicitaciones
didn't
por mi
want my
boda,
daughter's
quise
birth to
que
be known
sea
in all of
así.
Latin America, but
Ya estamos de
apparently
alta, fue
it's
hace
too
2
late.
días el
This
nacimiento,
was
así que
happened
nada,
two
ya
days
estamos en
ago. We're
casa
already home,
felices. Así que
thankfully.
la
So
verdad que un gusto poder
um,
que me hayan
so it's a
invitado y poder haber
pleasure
llegado.
to
¿Me
be able
escuchan,
to be
no?
here. You can hear me, right?
Sí, Manuel, perfectamente.
Perfecto, perfecto, por
Yes,
apagar las
yes, we
cámaras
can.
y pensé
Okay,
que no había
perfect.
problema. Bueno, de nuevo, muchísimas gracias por invitarme,
Once
por las
again, thank you so much
felicitaciones.
for
Como dijo
inviting me
Malén,
and for your
es un gran
congratulations. As
tema
Malen
de qué
said,
hablar. Hay muchos
it's a very
procesos y
important
muchas
issue to talk
intenciones en
about. There's a lot of
Latinoamérica
processes and
para
intentions in
procesos de
Latin
autorización.
America
Son todos bastante diferentes.
for the prioritization,
Y
and they're
bueno,
all very
acá vamos a
different.
tener
But here we're going to be
decisión tres
having
países. En mi
what
caso, ahora
three
desde la
countries
universidad
did.
voy
In
a la
my case, from
introducción
university, I'm
al
going to
proceso de
be giving an
priorización y voy a
introduction
explicar
to the
algunas cosas que se hicieron en
prioritization
Argentina,
process,
sobre
and I'll
todo
be explaining a
resultados, no
couple things that were
procesos.
done in Argentina,
Y
especially
eso
results
en el
of
tema de procesos
processes.
podemos ya involucrarnos
And
un
in
poquito
processes,
más
we
con
can
los
get
casos
involved a bit
puntuales de
more with
República
the
Dominicana
specific
y
cases
Uruguay,
of
por
the
ejemplo.
Dominican Republic and
Así que lo mío es un
Uruguay.
poco más introductorio y obviamente
So
mi
mine is more of an
participación
introduction, and of course,
como director
my
del
participation
organismo
as the
de evaluación de
director
tecnología de Argentina.
of the technology assessment body of Argentina.
Obviamente me pueden preguntar, pero quise que sea un poco
But
más académico, más de
I
introducción y
wanted
mostrar
this to
sobre
be
todo
more
resultados
academic,
que
more
hoy
of an
está faltando
introduction,
mucho en la
and
región, mostrar
especially
resultados
results,
de todas
which are
nuestras
missing a lot in the region, showing the
trabajos.
results
Así
of
que
all
ahora
of
estoy
our work.
compartiendo pantalla
So I'm sharing my screen.
y entiendo que
And
ya
I'm
ustedes
assuming that you can see it.
en
Por
modo
ahora no la vemos en
presentación.
modo presentación. Danos un
Yes, we see the
segundito.
presentation
Tarda un
mode.
poquito,
Ahora sí,
se tarda un poquito,
ahora sí.
pero perfecto. Bueno,
Yes,
también
yes,
como dijo Malén,
perfect. Okay,
somos
so as Marlene said,
el
I'd
centro
say we are
más
the
reciente que se incorporó a
most
RedETSA, así que estamos muy
recent center
contentos
that was
de podernos
incorporated to
involucrar, pero
RedETSA.
también de
We're
participar de
very
este primer
happy to
webinar.
have been
Así que
become members, but
para
also to
nosotros es
participate in this first webinar. So for
un
us,
gran puntapié a toda la actividad
it's
que queremos hacer
a great
sobre todo
starting point to
innovación,
all the activities
tecnologías
that we
y
want to have,
políticas de
especially in
cobertura en nuestro
technology
país.
assessment and coverage policies in our country.
Bien, un poco para entender el
Very
proceso de
well. So to
priorización, muchas
understand
veces
this
se habla de la
prioritization
priorización
process,
como
many times we
estas tres
talk about the
actividades, que es la
prioritization
identificación,
process
la
as these
selección
three activities:
y el mismo proceso de
identification,
priorización, pero
selection,
bueno,
and the
podemos ver
prioritization process.
de alguna
But we
forma
can
son
also see
equivalentes, pero hay que
somehow
entender
that they're equivalent, but
que
we
todos los
must
organismos
understand
casi
that all
siempre cumplen estos
bodies,
tres
almost
procesos, que es
always,
la identificación, la selección y
carry
la
out these three
priorización.
processes: identification, selection, and
Está bueno hablar
prioritization.
de que acá
It's
van a
good to
tener la
talk about the
experiencia
fact that
mía,
here and with my
Dominicana y Uruguay, que
experience
son los
in
organismos, las
Dominican
agencias
Republic
de
and
evaluación
Uruguay,
de tecnologías
it's the
sanitarias, pero
bodies
este
and
proceso se puede
health
lo podemos
technologies,
aplicar en cualquier ámbito.
but this
Eso es lo que
process
acá nos
can be
están viendo
applied in
profesionales
any
de la salud,
environment. I hope
estudiantes,
we have
por
healthcare
ejemplo,
professionals here, students,
financiadores
for
de obras
example,
sociales, empresas de medicina
social
prepaga,
works funders,
cualquier
prepaid
política de
medicine,
cobertura
administrators,
se
any
puede
kind of coverage
usar el
policy.
mismo criterio, y si
Uh,
tienen alguno ya desarrollado para su
and
país, como es en el caso de Argentina,
for
se pueden
example,
adaptar a diferentes
if we have
contextos. Así
in
que
our
yo voy a
country,
hablar
like the case of
por todo
Argentina,
lo que
this
se va a
can
hablar
be
acá
adapted to different
de agencia,
contexts.
pero traten de llevarlo también a su práctica a ver en qué les puede servir.
So we can take this to your practice and see
Primero,
what you
como
can
dijimos, es
use.
la identificación, que es la fase en que se generan y se recogen ideas, propuestas,
So as we
tecnologías e
said,
intervenciones que podrían ser
this
objeto de esta
gathers
innovación generativa.
ideas and things that can be
Y esto es importante porque puede ser reactiva o proactiva.
useful
Uno
for
puede
this technology
recibir
assessment, and this can
consultas,
be
digamos, por el
reactive or
caso de
proactive. You
Argentina, que
can
se
receive
reciben
consultation,
consultas
in the case of
y también es
Argentina,
proactiva,
where we receive
pero es
consultations and it's
reactiva.
also proactive,
Y
but
o
it's
uno
mostly
puede ir a
reactive.
buscar
Or we can go look
intervenciones,
for
tecnologías que podrían llegar
interventions,
a
technologies that could
evaluarse. Esto obviamente,
be able to
obviamente tiene que estar en
be
el ámbito
assessed.
donde uno se desarrolle.
And
Si uno se
this is
desarrolla también en
also
atención primaria,
in the
en primero,
environment if
segundo o
it's not
tercer nivel de
developed
atención, va a ser
in first,
diferente
second, or
lo que
third
estemos
level
buscando. Entonces
of
la
care.
identificación ya empieza
It's
como a
going to be different what we're
filtrarse
looking for.
ahí arriba.
So
Si
this
nos
is
interesa, si
filtered
somos un
from the top.
organismo que solamente
And if
evalúa
we're
medicamentos, si
interested,
somos un organismo que
or we're a
solamente
body that
evalúa
only assesses
dispositivos médicos, bueno,
medications
obviamente
or medical
lo que vamos a buscar,
devices,
o lo que vamos
or
a
what we're
tratar de
going to
identificar
be
es
looking for,
totalmente, va a
try
ser
to
totalmente diferente,
identify,
¿no?
will
Esto
be
también para comprender un
completely
poco las
different.
diferencias que
And this
podemos
to
tener entre
better understand the
organismos
differences that
en
we can have between
Latinoamérica.
bodies
Entonces,
in
ese es
Latin
el primer
America.
proceso.
So this is the first
Por ejemplo,
process.
nosotros en Argentina, en Conetec, lo que
So
hacíamos es,
in
lo
Argentina,
que también lo
what we
hacemos
did
en la
was
universidad, es
that we
dejamos
use this
disponible un
also in the
formulario
university,
en nuestra página
is
web, y
that we
entonces
leave a
cualquier
form
persona puede, de
available
alguna forma,
in our webpage,
postularnos nuevas intervenciones, nuevas tecnologías para evaluar,
and
y después el
we
proceso de
can
filtrado y
take a look at
después
new
la priorización corre
technologies
por parte
and
nuestra, pero
filtering.
es un proceso abierto y participativo. Cualquier
But
persona,
it's an
cualquiera que
open
esté
and
interesado,
participative
no tiene
process.
que ser
Anybody who's
alineado
interested,
con la política
and it
nacional
can
o
be
el
aligned
director
with
o el
the
tomador de decisiones
national
o
policy.
con los pacientes. Eso está muy bueno y nos ayuda muchísimo
And this is really good, and it
esta
really helps
selección
us
reactiva, esta identificación reactiva,
to have this
para ver por dónde pasan las
reactive
necesidades de la
selection to
población.
see
Eso nos ayuda
where the
muchísimo y le vamos a dar
population's
unos
needs are.
resultados.
This is really helpful,
Un
and
segundo
we will
paso que
show
es la
you some
selección, ¿no?
results.
Vamos filtrando
The
este
second step,
proceso,
which
cada vez
is the
vamos filtrando
selection, we will
tecnologías que
filter this
es un proceso en el
process,
cual, de entre todos los temas ya identificados, se filtran
and
aquellos que son
within the
elegibles para ser
identified
evaluados por
process,
el
this is
sistema de
filtered,
TESA y
like those who
verificando
are
su alineación
eligible,
con
and
el mandato,
verifying
el
the
alcance y los
alignment
objetivos de
to the
esa agencia, de ese
mandate and the
sistema, ese
objectives
organismo.
of this
También
agency
podemos
and
hablar
the
de que se
system and
puede
the
usar para
organism.
de
We
los
can
hospitales
say that this can be
en
used
este
for the
proceso.
hospitals Valle-Mecum,
Entonces hacemos ese proceso de
and
filtración.
we do
Algunos
this
tópicos
process
nos
for
parecerán que
filtering,
son
and some
interesantes, van
topics might seem
con
interesting.
nuestros objetivos. Yo les voy a mostrar el
Uh,
caso
and I
del
had already
Observatorio
showed you
Argentino
the
SETSAI,
case
que es
of the
solamente para
Argentinian
medicamentos
observatory set aside
innovadores y
for only for innovative medications.
es un criterio knockout. Quedan fuera a partir de este proceso de priorización.
So we have this
Y
prioritization
luego viene el
process
proceso
which
de priorización
knocks
en sí, que la
out
priorización no es más
um,
que
several
de alguna
aspects. And
forma
then we
hacer un
have the
ranking de tecnologías
prioritization,
y priorizar qué vamos a
which
usar
is a
primero, qué
ranking
después,
of technologies,
sobre todo
and
porque, como sabemos, hay
especially
restricciones
because,
de
as we know,
recursos
there
y
are
es
resource
importante dar
restrictions,
un
and
orden.
it's important to
Entonces, la
give an
etapa
order.
posterior a la selección,
So this
en la que
stage
se
is
decide
after the
entre los temas que
selection,
están
where we
elegibles, cuáles
decide
se evalúan,
within eligible
con qué tipo de
matters which ones
evaluación,
are
en
assessed,
qué
with
orden
which type
temporal.
of
Acá
assessment,
podemos hablar que algunos se van a evaluar, nos ha pasado en la
and
comisión que una priorización
sometimes
muy
it's
grande,
happened to us
entonces
in the
dijimos, bueno, los
commission
primeros
that
6
there's
meses
great
se evalúan estos, los
prioritization.
segundos 6 meses se evalúan los otros.
Um,
Otra cosa que pasa es, bueno, algunas
and another thing that
evaluaciones podemos hacer
happens
evaluaciones completas, que son evaluaciones que
is that
son muy
we can
largas,
do
que tardan
complete
más de 5 o 6
assessments,
meses y tienen otros procesos. Y para
five,
otras
six
evaluaciones,
months,
porque más
and
o menos la
there's
evidencia
processes
va para el mismo
um,
sentido y no
where
vale la pena
evidence is
gastar
going
tantos
in different
recursos en hacer una
directions, and it's
evaluación.
not worth it to spend so
Hacemos
many
evaluaciones
resources in
cortas.
an assessment. We
Un
do short
criterio, por ejemplo,
assessments,
que es interesante, que
a
tenemos
criteria
que
that is
teníamos, o por lo
interesting
menos que
that we
tenía yo cuando
had,
estaba en la comisión,
or I had when I was in the
es
commission,
si
is so as not to duplicate efforts. And as Alexandre was saying at the beginning, if there is a good quality document on the medication or the technology to be assessed. And the BRISA repository of assessment documents is very important. It has more than 5,000, I think, last time I checked. We search in these repositories in all of Latin America to see if there's an assessment of quality of good quality that could actually serve as a starting point. And then if I find it, I am going to use it. It's already been published by another country. And then I would try to answer the research question with that assessment. And then in a way, I would avoid having to do a full assessment that includes a lot of human resources, budget, and a long time. And as I had mentioned, given that not everybody can do the same kind of assessment at the same kind of depth because there are restrictions in different kinds of resources, then that's something that we have to check. So as a university, we have full assessments. There's a quick assessment sometimes when we have more limited resources, or we have the really quick consults, which are just documents, briefings that take approximately 1 week, so that you can sort of have an idea of what's going on. Sometimes we take 6 months, sometimes we take 2 months, and sometimes we just take a week. And this is basically based on the response times that we need. And another case that had a lot of impact in Argentina with collaboration from PAHO were the documents for COVID-19 and all the antivirals for COVID-19. These are living documents. And for example, they were updated every week in ultra-fast reports. And I say this because I don't want you to think that quick versions are of no use or have a lower quality. It's just about time. And sometimes, for example, in the pandemic, we needed a quick response. We needed to make quick decisions. Evidence is infodemia. And this really helps us make decisions. And there is no standard definition of the prioritization process, but I did want to leave here what should be the ideal prioritization. And this changes per region and this changes per country, of course. For me, these are the guidelines, and if you want to adapt them, I think that they would still have to be here. When you can change them a bit, you can switch up a couple things, but this is very important. It needs to be transparent and systematic. It needs to be an explicit methodology. For example, if there's a public consultation, it should be public, explicit. As I'm saying, the methodology and results. For example, who can actually present, who will assess, what are the results of this prioritization. And this gives a lot of transparency and credibility to all of our process. So one of the big assessments or one of the big points is that assessment should be transparent and systematic based on multiple criteria. This is not just one criteria, not just ISIT, not just cost effectiveness, not just clinical benefits, but we have to have different criteria. This gives more robustness to the technologies that we are going to be prioritizing. And as the title of this session says, optimizing the results. So some of the criteria that we use in the region are the burden of disease, clinical situation, quality of evidence. And another very important thing that I think we do very well in Argentina is that we are participatory. With the Argentinian bodies, patients don't just apply, but there's a roundtable of patients, and they work with a prioritization roundtable, and they can somehow, through their votes, switch up the order of the
Imagínense que los pacientes
technologies.
tienen el 20% de
Imagine
los
the
votos
patients have
en la
20% of
mesa de priorización,
votes
entonces tienen
in the
una probabilidad de 20% de
prioritization
cambiar
work table.
el,
So they have a
el
20%
orden final de
probability
esas
of
tecnologías. Eso
changing the
es una
final
muestra real.
order of these technologies. And this
Que
is
se alinea
very
con las prioridades
relevant.
nacionales. Acá
And
les
this
estoy
should be
usando
aligned with the
obviamente el
national
organismo
priorities. And of course, I'm thinking
nacional,
about this from
que
the
está bajo
the national
el organismo
body.
provincial
There is
en
also a
Argentina,
provincial body in
entonces tiene que estar
Argentina.
alineado, uno no
So
puede priorizar,
it needs
filtrar
to
o
be
evaluar
aligned. We
cosas que
cannot
después no
prioritize,
se van a
filter, or
implementar o que
assess
no hay
things
interés desde la
that are
política
not
para
going to be
implementarse, pero
implemented.
piénsenlo también
But
desde
think
un
about it
hospital,
from
un
your,
vademecum,
for example,
o
from a
incluso una
hospital
tecnología
or a
donde el
biomedical,
área
where we can take a
que,
look at a technology
digamos,
where
que
the
lo puede
area
administrar o se encargue, o la
can be
dirección de ese hospital no
administered
está
or
interesado
like
en implementarlo, o
maybe
el hospital no tiene, por
the
ejemplo,
hospital
el presupuesto, no tiene el
high
área para
management
poder
isn't
hacerlo.
interested,
Entonces,
or
esto
they
tiene que
don't
estar
have the
alineado con estas
budget, or they don't
prioridades
have the area to do it. So this
nacionales, o
always
en este
has to be
caso del
aligned with the
director
national
del hospital, por ejemplo.
priorities. In this case, for
Que sea
example, when we're talking
metodológicamente
about the hospital
robusto,
director, it should be
se prefiere un
methodologically
análisis multicriterio, que ahora se van a
robust.
presentar algunos
So
casos y no voy a
we
ahondar mucho en
rather
esto,
use
pero
criteria analysis.
eso
I don't want to
sumamente
delve on this too much,
está
but this is
buenísimo, y sobre
an
todo lo
interest
que
that is
hace,
really
bueno,
good, and
como les dije
especially
antes, en el segundo
what
punto,
makes
que
it,
va a
as I
ser
said
múltiples
before in the
criterios,
second point, that it's based on multiple criteria.
es un criterio knockout, o sea, lo saco, no lo saco. Todo esto tiene que estar, esto obviamente lo define cada institución, pero esto tiene que estar bien explícito. Y, por ejemplo, en Argentina tenemos un sistema de puntos. Cada uno de esos criterios iba de 1 a 5 y según esos puntaje, cada tecnología obtenía un puntaje final, para darles un ejemplo de cómo lo hacíamos nosotros. Y algo sumamente interesante, y yo habiendo sido director y obviamente de alguna forma toparme con muchas
I've been a
dificultades
director,
a la hora de tratar de poner todo esto a
and
punto.
when
Algo
facing
que siempre se tiene
difficulties,
que tener en cuenta, más allá de la
something you
idealidad
must
de ofrecer el
always
mejor
bring
proceso de
about and
priorización,
having
pero si no es
the
sostenible,
best process
difícilmente se podrá
civilization.
implementar.
If it's
Así
not
que
sustainable,
siempre
we can
cuando
implement
tratemos
it.
de
So every time
diseñar o adaptar estas
we try to
herramientas,
design or adapt these tools,
tenemos que ver el recurso humano que tenemos,
we have to see what's the human
el
resource we
presupuesto
have
que tenemos, los
available,
tiempos que tenemos,
the budget we
y
have, the
tratar de
times,
ser sostenible. Capaz que
and try to be sustainable.
una buena recomendación es empezar de a poco y
Hopefully,
empezar
a
a
good
crecer, como lo
recommendation,
hicimos en Argentina,
something a
pero
little bit of what we found in
que la
Argentina.
idealidad de ese proceso no choque con la realidad
And
del
for the
proceso.
reality of that process
Algunos
may
puntos
not
y
confront whether
beneficios
they're sustainable or
como
not.
dice la literatura, les dejé en la última filmina la
So
literatura para
in the
también un
last
poco
slide, I
parte
don't know
de
if you
mi
can see
experiencia,
the
es
literature, but a little bit of
este
my
proceso lo
experience
que
is that
hace es la
these processes,
optimización
what they
de
do
recursos
is the
limitados,
utilization of
enfoca
the
esfuerzos en tecnologías más
resources that at the end
económicos y
are kind of
económicos.
limited,
Si tenemos un
and a
buen
little bit of
proceso de
economic
priorización,
health resources, and if we have a
idealmente
good
tendríamos que
prioritization
tener
process,
unas tecnologías
then
que
we finally
podrían
should
tener gran
have
impacto
ideally
en la
technologies
salud
that can provide a great
del
impact
ámbito donde
in
trabajemos.
healthcare wherever the
La
setting may be
legitimidad y
where we're working
transparencia,
at.
entonces reduce la
And
discrecionalidad política y
transparency,
fortalece la fortaleza
working with
pública. Si
political
uno está mostrando
discretion and the
cómo dice el
public
manual,
reliance when you show what the
está diciendo
manual's all
qué
about,
personas, quiénes se van a encargar de los
and to
procesos
see what
y
are
después
the
publica esos
people in
resultados,
charge
que
of
les
the
voy a mostrar algunos
processes,
resultados de algunos procesos. Bueno, eso
and
le
to
da
look at
muchísima
the
legitimidad y
results of some
transparencia para
processes.
eso,
That
obviamente,
gives a lot
la
of
población analizarlo
legitimacy and transparency,
en
and
el
it
caso.
responds to that
Un
particular
diseñador sabe
agency
seguir
in this
en
particular.
evidencia, alinea las evaluaciones con la carga de enfermedad, necesidades
Now, talking
populacionales y
about
tratamos de
the
guiarlos de
possibility to
de
work
otros
with
aspectos
disease
que
burden and
no
other
suelen ser los más
aspects that
relevantes, en este
may not
caso,
be
en la
sometimes
política
considered as the
nacional,
most
¿no?
relevant in a
Que son los
national
más relevantes para la
policy,
política nacional.
but they are the most
La
important in
eficiencia del
national
proceso,
policy.
evita evaluaciones
Process
innecesarias con bajo
efficiency
valor
that
agregado,
prevents
como les dije,
unnecessary
o duplicación de
assessments
esfuerzos. Si tenemos una
or
evaluación
the
ya
doubling
de
of
buena calidad,
efforts
o cuando evaluamos la
and work
priorización, se
as
hacen evaluaciones,
better
por ejemplo,
quality
ultra
when we
rápidas. Vemos
have to
que
look at,
la
for
tecnología no
instance,
tiene un
quick responses,
beneficio
and we find that
relevante.
technology
Bueno,
has
entonces,
a relevant
de alguna
benefit.
forma,
So in a way,
queda fuera de ese filtro, o que podamos contestarlo con otra investigación, reduce muchísimo los
so we
tiempos y
have
la duplicación de esos esfuerzos.
the possibility to look at
La
these elements
participación
and
estructurada,
avoiding the doubling of
obviamente, si el
efforts.
proceso, como les dije, idealmente es
The
participativo, bueno, van a ir las
structured
diferentes
participation,
perspectivas y
obviously,
va
if
a
it's
ser muchísimo más
participative, we're
rico.
going to look
Es una
at
de
a
las
lot
grandes
more
experiencias
elements
que me
and it's
llevo
going to
yo
be
en
retest. That's one of the experiences I have been looking at in the commission is the work with patients, funders, politicians, prescribers. So truly, if one was to integrate these processes and make it more participative, most surely technologies being evaluated and recommended are going to have a consensus in the implementation, which is something that we are always having in Latin America, that implementation oftentimes is difficult. If we have an agreement in the implementation with all stakeholders, that implementation then it's going to become a lot easier. And then when we talk about strategic alignment, it connects all the HDAs with national priorities in healthcare and in universal healthcare coverage. That has to do with the organization's sustainable development goals, also with the WHO. So I'm not going to tackle topics for each of these countries, but I'm looking at countries according to the HTA network, which is complementary. So we can see a little bit of how these countries have some kind of prioritization process. And I found, for instance, that in Argentina, Uruguay, Barbados, Costa Rica, Dominican Republic, as we all have seen, Canada, Mexico, Colombia, Peru, and Chile have a prioritization process. And I bring this up so that you can have a wider landscape. We have just a few cases here, but there are some other countries that are also developing this. And it most surely, and if I just don't mention any, so what it has to do with public prioritization processes due to documents, we could mention this, examples. There may be other processes I may be ignoring, and my apologies for that. As I said, I was the director of the Connected, and during my administration in Santiago Torales, on board, we ran 3 processes of prioritization, 1 per year, and it was very interesting to find the results of how technologies prioritized were evolving, as well as those who were submitting requests for those technologies, so that you can see what the context was in Argentina. As you see on top, in 2020, we had 154 applications. In 2021, we only had 42, and 2023, we had 136. Now, these are not submissions per se, but once people would apply to these technologies, we would just put them together as a group. The requests and the applications were a lot more, but oftentimes were for the same pathology, so we were applying a filter. So in 2020, these are 124 topics, different topics to research for. In the 3 charts, in 2020, we can see that goes inwards, outwards from inside out, how they started to grow. As you see, the producers of technologies and pharma labs were the ones that were applying for the most for technologies, which remain in 2021, and in 2023. We were able to have more options or type of applicants. And here we worked a lot in what had to do with governmental entities and providers. The process obviously has to be participative. But what the agencies oftentimes lack is the communication of our processes, that our forms for application can get to everybody, from individual patients to providers, for everybody to be looking out to apply. So what started happening is that we started little by little with that kind of advertising. In 2023, we acquire maturity with it, with a lot of funders, with providers, with peers who were working, some of them in our very same building, some others were segregated, or some others didn't even know about this tool. They were able to know us, and we had a better application on that. what was about requested technologies. I imagine this happened in the whole region. And we're going to say in the whole world that medications in that time were the ones that took the most voting. So I'm not going to add anything to this. And in terms of pathologies, talking about oncological and chronic pathologies, were considered in 2023, the not frequent diseases were gaining more and more terrain. So I didn't put it in the slide, but when we saw this prioritization process, we decided to create quotas. We started creating quotas that was 100% of those technologies, and then 25 of them were used because mostly were medications or non-frequent diseases or non-communicable diseases and oncology. So we wanted to provide a diversity to our assessments. So we brought it up, and then the manual is quite explicit. We had 4 quotas with 25% for each. One of them is investment in medications. A second one is investment in devices, diagnostic methods. A third quota was for disinvestment, and a fourth one for the investment in non-frequent diseases. And this is something we did because one of the indications we consider was a populational impact. So it happened that the most population impact would said we would obtain more benefit in the participation or give more benefit for people to be a part of it. The detriment is that the non-frequent diseases were probably put aside, and a little bit to be like give justice or equity to access to these non-frequent diseases group, we had to bring them in, as well as non-communicable diseases and oncology. With this part, the Mendoza Health Technologies, the HTS, and the director, she sent me a slide for you to get to know this process, which through a participative approach, for those that are not from Argentina, you need to know that Mendoza is a province or a state, as they call it in some countries, that is the first one in the country having a unique agency. And it was recently created last year. Jorge and Lina, as part of the team, or colleagues working in this delegation. We already have the working plan written for this process. And so they submitted this process. I want to show it to you, the prioritization process in the Mendoza agency. These are 2 screenings in the Mendoza healthcare framework. Something very important to highlight here is the context of the applications. And what we're going to see here is that they created a quota system similar to what I told you, which establishes 25% for assessments for disinvestment and a 75% for the incorporation. 30%, the total will be for the first level of care, 45% for a second and third level. And this is because provinces or states in the country take care of primary care. And although the population per se was warranted in second and third level, provinces are also in charge of helping the public system. But the Ministry of Health, the first thing they have to ensure is their population primary health care, what is essential. So through a multi-criteria act and the participation of decisions in representatives, they had to work together with that filtering, with that screening of these quotas. And on the second, and that second screening and the value framework of the agency, more about a clinical and economic impact. Another multi-criteria analysis then is conducted, run by the agency and validated by the consulting committee at the agency. as a higher instance. This process has a participative approach, and it's consolidated in the annual working plan. And during the year, we ran this participation process. And lastly, I expect not to have taken too much of your time, but I share here an institution of health with a pharmaceutical lab. You can take a picture of the QR for those of you who are interested in looking at it. And on the very right side, you have the whole flow chart of how do we do our work with them, where you can clearly see an identification. There is a filter applier, prioritization. We already have that processing. Take into consideration the procedure in clinical excellence in the healthcare ministry of Argentina. But as I said prior, this is for medications which are defined as innovation and are not considered in the country. Basically, lately in RedETSA, you'll be able to see our documents that we use. I'm not completely certain that they're published, but do let me know. However, in a few days, you'll be able to access this document so that you can see them. And as you can see below, we have two evaluations, and there are two click buttons. And when we see an identification and evaluation forms. So in Argentina, all stakeholders are leaving their comments, and they are submitting these assessments that we filter and check. That has been a pretty good example of how the national body has placed a methodology that is then adapted by the Mendoza agency or by us, and it gives the process a lot more strength. I didn't say this, but it is also important to say that the assessment of all these methodology has a participative and multidisciplinary assessment, which gives strength to the work being done and the combination and the implementation of these technologies. And the last slide that I bring up, we can share, is where you can see the references, and I hope you were able to enjoy this presentation, and I leave this work that was supposed to be in 4 hours. I expect to have done it pretty good. Thank you very much, Manuel, for your presentation. I agree that we still need a little bit more advertising and communication to the institutions about the prioritization processes for all the potential interested parties to get to it. But I feel that some of the institutions in time are going to get to know more of these processes and having more of a shape. I find also very interesting what you say about the observatory, because it is also thinking about the scanning processes of how a tool and a criteria of prioritization. And about Brisa and what you asked, there were some inconveniences lately in the virtual library of healthcare, and we have not been able to update it. But we have been working in the updating of the set-side technologies report and some other institutions that are member of the data that we're also sharing in the last month.
Algo interesante que mencionaste ahí está muy bueno. Por ejemplo, el observatorio de la Universidad.
Something interesting that you mentioned, the Newcastle University Observatory, which is Innovation Pharmaceutical Lab in the UK, works with the filtering and the screening for the UK. And these are the scanning of the horizon. So they're already looking at technologies that they are authorized to look into. So it's also important to update the horizon scanning. So times are shortening a little bit more. I think that improves access in the end to technologies that are of value. Before we continue, I want to remind you that you can leave your questions in the Q&A, which is below in the Zoom menu. And then our second speaker, Madeline Martinez Garcia, she is a bachelor in economy with a master's in financial administration, specialized in healthcare economy and assessment of healthcare technologies, including a PhD in healthcare technology from the School of Management of the Punta Fabra University. by the National University of Comahue in Argentina and a specialization in economical assessment by the University of Antioquia in Colombia. She's currently working as the Director of Economic Studies and Statistical Studies from the Superintendence of Healthcare and Competence Work in CISES. Go ahead, Marlene.
Hola, hola, buenos días. Bueno, ya Marlene me presentó, entonces ya no tengo que
Good morning,
decir
everybody.
nada,
Madeline
pero
already
pues
introduced me, so I
creo que aquí
have
hay
very little to
muchos
say about me.
compañeros que nos conocemos
There are
y
some
que nos hemos
colleagues that
saludado y
I
dado un
have
fuerte abrazo
already
durante
known, and we've
algunas veces que hemos estado presencial.
been able to
Bueno,
share a
yo
very
voy
good time when we
a
have been
comentar
together in the same event.
la práctica.
I want
Ya
to bring
Manuel le ha
about
estado hablando
the
un poco
practice. Manuel has been
de cómo ha
saying
estado todo
a
este
little bit of
proceso,
how all
de cuál
this
es la
process has been
importancia, por
doing,
qué las
of what's the
agencias
importance and why
necesitan hacer
agencies
procesos de priorización.
need to
Y en
work
este
with
caso yo le
prioritization
voy a hablar
processes. And at this
del
point, I'm going to talk
proceso
about
de cómo llevamos
the
toda esta
very
teoría
process of how we
que
take all this
durante
theory,
mucho tiempo
which for
dentro de las
many
agencias que estamos
years
en
in
la
the
región
agencies
hemos
that we represent
conversado
in
de
the
cómo lo
region,
hacemos,
we've
cuáles
talked
son
about how to do it.
aquellas prioridades
What
o
are
demandas que
those sort of
tenemos
priorities or
constantes
demands that
y
we're constantly
cómo
having,
hacer que
and how we
tal
do
vez todo
that sometimes
el proceso sea de una
we
manera más ágil y
can
más
help the process
transparente.
to be a little
Pero sobre
swifter and
todo
more transparent.
también,
But most
cómo
particularly
podemos
thinking of how
operativizar y
can
que
we
sea totalmente
make the operation
transparente la forma como
in
tomamos
a
las decisiones.
in a
En
better
el día
way
de
and a
hoy
more
yo le voy a
transparent decision
mostrar
making. So
en la
today,
práctica cómo
I'm going to show
hacemos
you in the practice
desde República Dominicana el proceso de
how do we do it from
priorización
the
y
Dominican Republic,
especialmente desde la
this
Superintendencia de
prioritization process,
Salud y Riesgos
particularly from
Laborales.
the superintendents of healthcare and compensation risks.
Entonces, lo primordial antes de hablar de un proceso de
What's
priorización,
paramount before we
como
talk about
decía Manuel,
prioritization
es
processes, as Manuel had
institucionalizar el
said, is the
proceso. Es decir,
institutionalization
cuáles
of the
son aquellas
process.
bases o
So
criterios
what are the
que van a
basics, are
sentar
the
lo
criteria
que va a venir
that
adelante.
are going to
Para el
give
caso
a
de
baseline to
República
what comes
Dominicana,
ahead?
nosotros en
For the
2022, mediante
Dominican
una
Republic in
resolución
2022, through
emitida
a
por esta
resolution
superintendencia,
issued by
creamos
these
todo el
superintendents, we
proceso.
created the whole
¿Cuáles iban a
process.
ser aquellas
What were
actividades
going
que
to
iban
be those
a
such
dictar el
activities that
camino
were
de la
going
priorización?
to pave the
Y
road to
esta
prioritization.
resolución, que es
And this
pública y está
resolution,
de
which is public
conocimiento a
and of
todos
public knowledge
los involucrados,
to all those involved,
está dictada para crear
is
una mesa de
created
priorización institucional,
for an
la cual se
institutional
compone de 7
group
miembros y está
comprised
liderada
by
por el
7 members
superintendente
and led by
y
the
donde participa no
superintendent,
solamente el área que es
where
encargada de hacer estas
the
evaluaciones
area in charge of
epidemiológico-sanitarias,
working with this
sino que
healthcare technology.
participan aquellas áreas involucradas en la construcción de propuestas
But it also has a
y
participation of areas
los
that have to do
análisis
with the
pertinentes para
construction of
incluir
proposals,
una
and they give an
cobertura
analysis
dentro
to
del plan de
include
beneficio que tiene la
a
República
coverage
Dominicana en el marco del seguro familiar
in the
universal.
Dominican Republic in the
Lógicamente
framework of
tiene
family
una área
healthcare.
que es la que coordina todas
There is
estas
an area
solicitudes y
that
que va a ir
coordinates all
dando
these requests
cumplimiento a que el
and
proceso se
that
cumpla.
fulfills or helps this process to
¿Qué
be
pasaba
fulfilled.
y por qué tuvimos la necesidad de crear un proceso de priorización? Bueno,
Why did we
básicamente
have to do
porque,
this
como
prioritization? Well,
decía
basically,
Alexander en el
because as
inicio,
Alexandra said at the
tenemos
beginning,
una alta demanda de
we have a high
solicitudes
demand
que nos
of
generan desde
applications that
distintos
come from
actores del sistema
various
que necesitan
stakeholders in the
incluir
system
nuevas
that
tecnologías,
need
ya
to
sean
include new
procedimientos,
technologies,
medicamentos,
call
dispositivos,
them
dentro
procedures,
del plan de
medications,
beneficio.
devices within the
Ahora, los
benefit plan.
recursos son
Now,
limitados.
resources are
Creo que
limited.
eso pasa en toda la
And I think
región,
that
que los
happens
recursos
all
son
over the region
extremadamente
where resources
limitados,
are
pero
extremely
también
limited.
los recursos
But
técnicos
also
para poder
technical
producir
resources
estos
to be able
informes
to
son
produce these
limitados.
reports are limited as
Y
well.
lo que sí no cambia es
And
la
what does
demanda
not
y la
change is the
necesidad de
actual
incluir
demand and the need to
nuevas
include
coberturas a los
new
planes de
coverage
beneficio y
to
que
benefit
éstas puedan
plans
ser más
and for these
eficientes.
coverage to be a lot more
Entonces,
efficient.
nosotros desde
So
2023
since
hasta la
2023
fecha
and up till
hemos
now,
tenido
we
N
have
cantidad de
had
solicitudes,
X
las
amount
cuales
of
el
requests and applications where
60.17 está
60.17% of
haciendo
them
solicitudes para
are
alto costo.
being
Es
for high
decir, que
cost
son
applications.
solicitudes
That
que
means
van
these are
a tener
applications that are
un
going
alto
to
impacto
have
económico.
a high economic impact.
¿Y esto qué pasa?
So what
Que otra
happens with
cosa es la que
that is
veíamos es
that
que
the other
creaba un
thing we were looking
desbalance
at is that we
porque
create an
tenía
imbalance because we had requests that were high cost, but also that were oriented toward healing processes more than preventive processes. That was also creating inequality between the applications that we were receiving, as well as a constant external pressure from a variety of entities within the Dominican Republic that were pushing to include their technologies within the benefit plan. And the one that could push the most, or the one that could have the most advantages to provide, were the applications that we're going to be learning about first. So what did we decide on and why this process came about? Well, we created a pathway. It is a public route for all those that within the system and within the Dominican Republic are working to include their technology. So the first thing we do is the call process. It's a public call. It's published in the website. It's published in the sessions that we've intended for the assessment of healthcare technologies. And when we call that process, it's also in every area that needs to apply them. They're received twice a year. And this does not mean that those two occasions a year are the only window of time for them to be sent. They have the whole year to do it and to send them, but they're only going to be looked at once these two time opportunities are provided. In addition to this process, we also create a whole system, a platform that allows to have a feedback between the applicant and ourselves, because it goes into a process of revision. It was important for us that these applications we receive are having the needed features, meaning indicating what is the population that is going to be served, what population are they going to be covering, that they can be explaining what are the specific stages or if they're requesting in the case of a high-cost application, most particularly. But what's most necessary is for us to have information on whether they have real life evidence data, if they have studies that maybe they want us to consider, not only what we would be looking at the time of running analysis, but to also allow to receive information from them in this verification process for it to be more interactive. Then we move toward the primary criteria phase in order to assess these requests. And we're going to see how we develop them. And then our conclusion, which is the second phase of analysis, where we already have a score prepared for each of them that allows us to know what we're going to do ahead. If we're going to have an actual healthcare technology assessment to be able to include it in the catalog, or at that point, according to the features that particular technology shows may not be feasible. So this is how we do it. On the first step, our interest being, since we've seen other examples in the region, has been able to convey to you how is it that we run this prioritization process and an operation standpoint. So the first step, as I had said, is that public call, where we call it the public knowledge call. It's done twice a year, and they have a window of 15 days, 15 working days, with pharmaceutical companies, medical associations, patients associations, or any other that is affiliated into the Social Security system. They can submit their request. Channels are structured, and these are completely friendly platforms for every applicant, and they allow to look into what is the information they are submitting, and also reading any other information that may not have any background as well. It has a whole scheme of requests and automatic processes, because this process is going to filter the flow for the teams, and so that they don't have to be working way too manually. So it automates the whole feedback process and the response messaging. received by applicants once they have completed their requests and applications. So we designed two big phases, where the first one has the purpose of having legal viability and strategic alignment, because it is important that they work together with how the countries are doing it. They are prioritizing what actions or what diseases they want to analyze or include within their plans, and what are the national priorities they want to work with. So in that first time, they have two sets of criteria. And it also has an approach to analyze the local setting, but most particularly, what are those goals within the superintendents and within the Dominican Social Security system to be able to incorporate and improve within the catalog. In a second phase, there's going to be a more comprehensive approach. This has 4 dimensions, and it's basically focusing on the clinical and social aspects to conduct this measurement. This is like a big perspective of it. Now, more specifically, let's take a look at that first step, that first phase. The interest here is to show what's the viability of this application within the country and whether it's going to be possible to bring a proposal along. Because we may receive 100 applications, but without economic viability and country priorities not focusing on that technology, then it is possible that only these teams are going to be strained, and they need to focus on those requests that are being subject to proposals within the system. So how do we see this? And this has 3 big dimensions that go between 25 points that are spreading as the importance and the goals that the superintendent has. 50 points intended for the availability in the Dominican Republic to have these technologies, because we cannot be assessing those such technologies to lack a healthcare registration or availability to be supplied within the country. That means that many times when we assess the comparison or the intervention, if it doesn't have a regulation or an availability within the local territory, it's not worthwhile, because when incorporating it, it would be a technology that wouldn't be available for the population.
Then there's 25 points that are oriented towards the national priorities, and these are dictated to the availability of the Ministry of Health or the Presidency of the Republic. So meaning that it has a coordination between the national priorities and strategic priorities that the country has. So the second stage, we have a more measurable impact of the technology. And here we see 4 dimensions. Here we see a social dimension, which will question what is the real demand that the technology has for us to know, which would be the number of people who could be demanding and benefiting later from the inclusion of this technology. A clinical impact, and this is a very important impact to us. Why? Because many times when we do the analysis of this clinical impact, we see it with what we have today within the benefit plan. And this allows us to be able to learn which would be the real impact in terms of health at the moment of incorporating this technology. And then we have a population impact, where we see what is the expected population who would be receiving this technology, and what number of people we could be benefiting once incorporated. And then we have an economic impact. And this is very important, because here we assess what would be the real cost of this medication. And then not only the specific cost of purchasing the medication, but also if there's coadjuvant medications or others that are provided together with this medication, how the medication is delivered, if we have to give it in the hospital, or if they need some sort of special care, or if they have any other analysis or tests that should be taken before administering the medication. All of this is considered to be able to analyze the economic impact of a future incorporation of this medication. These two criteria that we're seeing here, or these two dimensions, have an important phase. Why? Because once we've seen this allows us to learn and see which are the special exact combinations. And what do I mean when I mention this? Each one of these things, like social demand, clinical demand, economic demand, has scores that go between 0 and 3, and then logically they go hand in hand into a translation into points that puts each one of these stages into a total score. And this will also allow us to rank, after having the score, which of these go to a later analysis. And why is this important? Because we see that there's a request process that analyzes, but the prioritization process allows us to optimize not just what we are receiving, but also the priorities, and that this go hands in hand with the national priorities, and at government level, and also analyzing the availability that we have installed personally, economically within the superintendents. And what does this do? It allows us to do two steps. One, focus on knowing the weight or the need that we have with this technology, to then go to an assessment, and allows the most important things, which are having very clear and transparent criteria on why we choose one technology over another. And this also allows ranking the real needs. Why? Because all of this is translated into a total score of the technology that allows us to know what it is that we're going to be assessing first and what we'll be assessing later. This request, once completing each one of these prioritization processes, allows to create a documentation. And this is close to 6 pages, where we issue this to the requesting party. Once having completed the period, we have 15 days or 2 weeks for the call, and 30 days to respond based on this document. Once I've completed this time or before, the requesting party receives this document that allows them to know if their request was prioritized or not. And if it wasn't, it allows them to know the criteria or the points where they didn't get the maximum score and that didn't allow them to be prioritized right now. But above all, I think that this document or this mechanism of prioritizing allows us to be able to clarify why not. I always say that it's easier to say yes than to say no. Why? Because the no has to be justified, and especially when everybody understands that their request has an impact and that it will generate a favor on the population. So it's important for us to be able to indicate which are the criteria in which we're saying that right now the request was not prioritized. And this also goes with a very explicit note where it indicates the requester that they have 2 years to do the request again for this same technology, for the same population. It doesn't mean that there's a different indication this technology has to wait for 2 years. No, just for the indication in the technology that was requested in that moment. Once we have the results of this prioritization, it goes to the stage
En esta etapa de evaluación
for
ya
assessment.
se hace todo el proceso que todos conocemos para
And
hacer
then we do the entire
una
process.
evaluación de tecnología sanitaria o una evaluación económica y
We
poder
go to
hacer
an
ya las
economic
recomendaciones
assessment or
en
a
cuanto
healthcare
a inclusión de
technology
cobertura y
assessment, and
políticas
then
de
we do the
cobertura que
recommendations
van a
for
ser
the
posterior
inclusion and
sujeto a la
policies
decisión de
for
incluir o no
coverage that will
la tecnología
basically decide
solicitada en el
if
plan de
the
servicio
technology
de salud.
requested will be included or not in the health
Entonces,
service plan.
para nosotros todo este proceso es
Then for us, this entire
transparente a todos los
process
factores. Y hoy
is
está
transparent to all
público dentro de
stakeholders.
la página web de CISARRIL y dentro de la sección de
And
EFTESA, que es la
then
sección que nosotros
nowadays it's
tenemos
public
estipulada
within the
para
ETS section
capacitar y dar información a los solicitantes.
that we have
¿Y por qué lo
to
hicimos así? Porque
send
para
information
nosotros
to the
era vital
requesters.
para la
And why
superintendencia
did we
crear
do
un
it like
proceso
this?
transparente
Because it
y
was
que
vital for
genere
the
la
superintendency
confianza.
to create a
Este es un proceso que
transparent
va a no
process that generates
solamente
trust.
ser transparente y generar confianza, sino
And
que
this leads not only
también
to being
va a crear
transparent and
ese
generating
lazo
trust, but
de
it will create this
diálogo entre ambas partes.
liaison of dialogue
Y
between the two
también
parties,
legitimiza todo el
and
proceso de lo
also
que estamos haciendo.
legitimizes the entire
Entonces,
process of
¿cómo
what we're doing.
garantizamos que este proceso
So,
nos genere
how do
valor?
we guarantee that
Primero,
this
porque
process
estamos
generates
tomando
value?
decisiones de
First of all, because
cobertura
we're
para el
making
catálogo
coverage
que están
decisions
basados en la
for the
transparencia
catalog
y
that
que
are
son
based on
públicas.
transparency and
Segundo,
that are
porque
public.
eficientiza el uso de los recursos, es
And
decir, que no
second,
estamos
because it
tomando
makes more
decisiones
efficient the
de
use
qué
of
priorizar
resources.
primero, qué priorizar
So that
después,
means that we're not
solamente
making
por
decisions of what to prioritize first and what
circunstancias
to
o por
prioritize later,
presiones
but
de
based
grupo,
on
sino que lo
circumstances
estamos
or
haciendo
pressures
basado en un
from the group,
criterio
but we're doing it based on a
medible para
criteria
todos, es
that
decir, que
is
todas las
measurable for
solicitudes tienen el
everyone.
mismo trato. Segundo, porque
So each request
garantiza
is
un
treated exactly the
acceso
same. Second, because it
mayor para
guarantees an access, a greater
tecnologías que van a
access
tener un mayor
for
beneficio
technologies that will
y
have
que
a
para
greater
nosotros,
benefit.
dado a los análisis
And for
previos que se
us,
hacen,
given
va a
to the
tener un
previous analysis that
beneficio
have been
clínico
done, this will have
comprobado
a
al momento de
clinical
introducirlo a
benefit that
nuestro
is proven
catálogo.
when introducing it to our catalog.
Sí, como todo proceso, no tenemos un proceso
So, like in
totalmente
each process, we don't
permeable
have
y
a
perfecto,
process that's
por lo
completely
cual
permeable
cada
or
2
perfect.
años nosotros
Therefore,
hacemos
every
una
2 years,
revisión de
we
estos
do some
criterios.
revisions
Este
of these
año tuvimos
criteria.
una revisión de estos criterios y que luego, más adelante,
This year,
a
we had the
mediados de año,
revision,
vamos a estar haciendo el
and then
refrescamiento
later
de
on in
este
the middle of the
manual de
year, we're going to be
priorización institucional
refreshing this
que tenemos
institutional
colgado
prioritization manual that
a
we have
disposición de todos, en el cual
available
vamos
for
a estar
everyone,
haciendo
in
este
which we're going to be
refresh
doing
de
this
este manual.
refresh
¿Por
of
qué? ¿Y
this
por qué lo
manual.
hicimos? Porque como Manuel
And why?
hablaba
Why
en
did
su
we do that? Because
presentación,
as Manuel was saying in his
cambia la
presentation,
forma en cómo las
um,
tecnologías llegan. Hoy
this
por hoy
changes
nosotros
the
tenemos
way
una
that the technologies arrive. So
alta
nowadays, we
demanda
have
de
a
solicitudes de
very
alto
high
costo.
demand
Pero ¿qué
of high cost
pasa con
requests.
esas
But
solicitudes
what
que van
happens
orientadas a
with
prevención?
the requests
¿Qué
that are
pasa tal
focused
vez con
on
esas
prevention or
solicitudes
the ones that
que
are
van más orientados a
focused
procedimientos?
more on
¿Qué pasa con esas
procedures?
solicitudes que van más
What happens with
orientadas
the
al
requests that are
positivo?
more
Muchas veces, si lo que
focused
recibimos
on different things?
constantemente
Many
son
times,
medicamentos,
what we
se
constantly receive
pudiesen
are
quedar
medications.
olvidados.
They're,
Entonces,
they
el
these
catálogo
could
tiene
be
que ir
forgotten or left behind. So
actualizándose
the catalog
y ir
needs to be
ajustándose de
updated
acuerdo
and
a las
adjusting
prioridades
based
para todos.
on the
Entonces,
priorities for
es por
everyone.
esto que
So
este año
that's
hemos hecho
why
un
this year
refrescamiento de estos
we've done a
criterios y que
refresh
vamos a
of
estar
these
publicando
criteria
a
that
mediados
we will
de
be
junio.
publishing in the middle of June.
Aquí les dejo para respetar el
So
tiempo
I
que
leave you
nos han
this
dado a
because I
cada
want to
uno como
respect your time.
expositores. Una infografía de qué es la
And
evaluación de
it's an
tecnologías
infographic
sanitarias
of
en la
what
República Dominicana y sobre
the
todo en el marco del
health
Seguro Familiar de
technology
Salud
assessment is, and
que
especially
hoy tiene
in
la
the Dominican
Superintendencia de
Republic,
Salud y Riesgos
especially
Laborales.
with what the
Nosotros tenemos
superintendents
una
of
página donde tienen
health and
informaciones de
labor risk
manual,
has, and we have a page
información
where there's
desde el
information on
manual de
manuals,
priorización, con los
uh,
criterios, con las
with the
puntuaciones, con
criteria,
las
with the
calificaciones
scores,
para cada uno de
with,
los casos.
with
Incluso ya
the
tenemos
points for each one
muchos
of the
solicitantes
cases.
y actores que vienen a
And we
nosotros
have a
ya
lot of
con
actors that
ellos
come to
mismos,
us
ha hecho su proceso
and they've
de
done
priorización.
already
Y
their
esto para nosotros,
prioritization
más
process. And for
que
us,
verlo como algo
more than
negativo, lo vemos
seeing
como
this
algo
as
positivo
something
porque
negative, we see this as something
hace
positive
una
because it
legitimización del
legitimizes
proceso
the process, and especially allows us all to speak the same language, that nobody feels that we are doing incorporations or improvements or updates in the catalog because it's the demand that's being received. No, but we are going in and assessing medications that will contribute a clinical improvement and a real benefit to the population that we have today. And I think this is the most important thing. Additionally, to the fact that the prioritization processes are processes that must be transparent. And I want to leave this maybe like the improvements for everyone who is seeing the example of the Dominican Republic today and would like to replicate it. They have to be transparent processes. They have to be processes with dialogue, not just that decisions are made from one single body, but this must be collective and to be able to see other criteria. But then they also need to be a process that allows making decisions for prioritization on what it is that we should include that really generates value for society. So, this is my experience, the experience of the Dominican Republic. As I was saying, it's a process that allows us to be able to weigh which are the things that we're going to be assessing first and what we're going to be assessing later, but not leaving behind or forgetting those that don't have that are not in first place. So this is a process, the operation of how we do this. I hope it's been useful for all of you and that it helps you to make the best decisions possible at the moment of incorporating your technologies.
Muchísimas gracias, Madeline.
Thank you so much, Madeline. So the advances that CISALRIL has done in the past few years are a lot, and a great example or a valuable example for other countries in the region. I'm so thankful for you for having shared this experience. Our last speakers are Ana Perez and Alejandra Grossi from the Health Technology Assessment from Uruguay, who will be talking about the history of prioritization of technologies in the country and the current processes. I want to clarify that from being that we started late and the speakers are giving us their time with very long presentations, we're not going to be able to have a Q&A session as we always have, but I invite you all to write down your questions in the Q&A. Manuel already answered a couple, and Madeline and Ana and Alejandra can also reply to the ones that have that are relevant to you, or any new ones, so that people can have their answers. Now we start with ETSO. Ana is a physician by Universidad de la República, specialist in health administration and epidemiology with a master's degree in health systems from Montreal University. She was responsible for regulation, investigation, research of health technologies in the Public University of Uruguay from 2020, and she currently works in the Health Technology Agencies of Uruguay, AETSO.
Con posgrado en gestión de servicios de salud, diploma en salud pública y formación en epidemiología.
And epidemiological training. Also with many years of experience in the Public Healthcare Ministry, HDS, and Economic Assessment. Since 2023, she's a member of the Technical Council of HDAs in Uruguay as Senior Assessor. Go ahead with your presentation. Yes, quite shortly. I just wanted to point at the origin of what is the development of prioritization in Uruguay. We go from the Subcommission of Healthcare, Mercosur, and many of you may know about it. Maybe some of you have or also been a part of it. Alexandria and myself were a part of this commission where multiple tools are developed And as you can see, now the various countries, there's a lot of effort being to get. We're working in different dimensions, and the tools are quite similar. What happens then in regards to the use of tools? They are used for the selection, to evaluate, but they're also used for prioritization. And this is what Alejandra is going to portray in a minute. And this is a situation in Uruguay. And so what I wanted to highlight in Uruguay is that there is a strong coordination and a relationship between all the groups that have to do with HDS, which are members of RedETSA, which is the Public Healthcare Ministry, the HTA's unit from the universities, the National Fund of Resources, and ourselves as AETSU. So we're adding that value of coordination among all actors engaged into HTAs in Uruguay. So that's all I wanted to add. Continue. Okay. Hello, everybody, and good afternoon. A pleasure to be here with you today. After Anna's presentation, I now continue by sharing with you what the experience is in Uruguay about the prioritization that, as the prior speakers have mentioned, they've already provided a theoretical framework of prioritization, so we're not going to delve into that much further. But we are going to share with you what happened in Uruguay and what has been happening lately.
Bien, en Uruguay, desde hace bastante, la recepción de las solicitudes.
For quite a while in Uruguay, the reception of applications are open. They're received by the Public Ministry of Healthcare in the website. There is a form that anybody can fill out. It's a form called Incorporation Requests for the National Healthcare Ministry, PIS, which is the one that provides information about what's covered by our system, and then this FTM, which is the actual form for type of medications, per its acronym in Spanish, and it pretty much explains what are those medications that are covered by this system. So we have that call being done from January 1st every year up until June 30th, where you can submit applications from the academia, from the patients, or from any act. From February 2025, the ministry, the healthcare ministry, summoned all the representatives of different patient associations and representatives of the academia as well, so that they could bring their applications up, those applications that they thought that it should be responded to. Once these external applications were received, as well as patients' applications in the academias, and added to what existed earlier, because this process has been in Uruguay for many years, in receiving applications of PIAs in corporations. And when the list was available, we found that there was a big gap in Uruguay of where the high-priced technologies, which are funded in our country, but the National Fund of Resources, well, there were many medications or devices that were funded and had been incorporated into the coverage, but there was a huge gap in what it has to do with low-price HTAs or the most basic or the primary care level ones, so that they're not funded by the FNAR, that do not require funding. That's when we saw that we needed to conduct a different kind of prioritization, meaning emphasizing those such technologies that were delayed, those that were left behind. So we're talking about basic technologies. And so I'm going to refer to one of them, for instance, which is prostaglandin, which is a medication that is quite used and not added into the coverage in Uruguay because years and years passed and was not incorporated to the FTAA. So the public ministry issued a list to prioritize those such technologies that had to do that had to be valued that needed to be incorporated into the FTA. A group was established, a team, such as the one Anna referred to, with members from the Abelar, FDAR, the Ministry on AETSU. But there was a specific team with members of the AETSU and members of the Ministry of Healthcare, the Public Ministry of Healthcare. It was a lot of work to do to take care of this prioritization list. Once the list of medications was completed, those medications that were left behind and that needed to be added were submitted to AETSU to look into ultra quick tests with reports that were done really quick as well, focusing scientific evidence to them and that provide information to be able to apply the prioritization tool that Uruguay has. And that's pretty similar to, as Ana said, to what was presented before. They contain the information specific to each of these technologies so that we could have some kind of idea to what is it that we need to prioritize, incidence, prevalence, severity, all the information that is. So we share it with the members of the team. And it is also important to highlight that upon the application of the tool, we noticed that tool needed certain adjustments. So these adjustments were done at the time, but toward the future, it is believed that this prioritization tool, which is available in the AETSU website, is going to have deeper modifications to allow more rigorous study. So the working group in the ministry, with each one applying about 10, 25, 30 technologies, each of the members applied that and then they found the final score obtained. Then they conducted a consensus between the ministry and AETSU to try and establish a final and unique scoring. After the final scoring from MSP, which is the Public Ministry of Healthcare, what they did is they created a call, summoned to a variety of physicians in a variety of specialties, so that they could give their opinion and they could bring their input on what on the score that had been given to each health technology. Clinicians brought in their knowledge, their wisdom for some specificities of the tool, like their input on incidence, the severity of the healthcare condition, the impact in public health, which is very important to learn about, particularly available therapies. Oftentimes, those that are not in the direct clinical treatment are not so clear about it. Also, what was the expected clinical benefit upon applying this technology? So that was the clinician's opinion. Of course, the tool also considers other dimensions such as equality, demand, and so many other elements that maybe clinicians had not a lot of knowledge to put their input on. But so in this particular, it was very important that they would give what their opinion was. And then they reached a final score. And so each technology, in this case, medications, had a final score. They were organized from the more to the least. And this final list was then submitted to the commission like 2 hours ago to the Public Ministry of Health. And so then once having ranked these technologies, they can be considered by the national authorities for them to make decisions on what they need to incorporate, what they need to bring into the therapeutical form of medications. And well, that's the most recent experience for Uruguay, a very recent one. And that's it.
Muchísimas gracias, Alejandra.
Thank you very much, Alejandra and Ana, for the excellent presentation and for showing AETSU experience.
Los oradores del día de hoy han sido excepcionales, todos demostrando
Certainly
pasión,
today's speakers have
entusiasmo y
been
mucho
exceptional,
detalle
showing
en
passion,
los procesos de priorización de cada
enthusiasm,
una de
and a lot of
sus,
detail in the prioritization
instituciones
of each
y
of
sus
their
experiencias.
institutions and their
Les agradecemos,
experiences.
les agradecemos
And so
mucho
we
y también
thank
haber
you
podido
very much
responder
and
en
to
la
have been
mayoría
able
del
to
chat
also
las
respond
preguntas.
most
Por,
questions
falta
in
de
a
tiempo
chat
ya estamos pasado,
function.
no
And
vamos a
due to
poder
lack of time, we're over
realizar
the limit of the time that we have provided for the space. And so we cannot conduct our Q&A session. But Manuel, Marlene, and the AETSU girls have been able to answer to each of the questions in the chat. So we thank you for that, guys. Marlene, if you're there and if you want to turn your camera on for a final greeting. I want to also tell you that we're going to send you all the slides if the speakers agree in the form of PDF, because there is a lot of interest in them and a lot of people are asking us to send those slides. So please remember that in a few days you're going to have the recording available in the RedETSA's website. For all of you, I want to invite you to the upcoming trainings. We are closing the registration for the next webinar on May 8th on agreements based on results. So 2 weeks prior, we're going to publish information on the RedETSA website, www.redetsa.org. And also to all of you who are enrolled in our distribution list and all the members of RedETSA that we are in constant communication with. So without further ado, have a wonderful weekend, and particularly for the new dad, Manuel. So have a wonderful weekend together as a family, and thank you for being with us.
Gracias a ustedes. Bye bye.
Los saludos.
Gracias.
Chao.